Well, some of you astute people that do a lot of research on your own, your self-health advocates, which is what we call you here, you ask about glutamine and its association with prostate cancer. Well, today I have a conversation with an expert, Dr. Jun Gong, on that same exact topic. What is, from a scientific perspective, not just what you're reading on the internet, not what you think is the truth, but what is really the connection between glutamine, an amino acid, and prostate cancer. Dr. Jun Gong is a medical oncologist of gastrointestinal disease, pancreatic cancer, and urologic oncology program in the Samuel Alshin Comprehensive Cancer Institute at Cedars Sinai. His primary clinical interests are in GI, hepatobiliary, and genitourinary cancers with multidisciplinary focused care with colleagues from surgery, gastroenterology, radiation oncology, radiology, and urology. Dr. Gong is focused on translational and clinical cancer research with interest in early therapeutic trials, things like immunotherapy, targeted therapies, biologics, and other systemic therapies, and biomarker development to improve patient outcomes in GI and GU, urological cancers. He has published quite a bit on glutamine, and he's given the lowdown on glutamine and prostate cancer. I'm not going to give it away, but I'll tell you, it is good. You're going to like it. Also, go ahead and go to drgeo.com because I write about these things to our newsletter subscribers, things that I don't normally get to say on the podcast or written anywhere else. In other words, if I see a clinical insight, if I read something, I send it out in a newsletter with actionable points to self-health advocates, which that is what most of you are. So sign up to the Dr. Geo newsletter, drgeo.com. That said, no longer wait any longer. My conversation with Dr. Jun Gong on glutamine, the association of glutamine and prostate cancer. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo Espinosa, and my goal is, as always, to bring you the best of the best in terms of natural approaches, lifestyle, nutritional science, conventional medical treatments that actually work with experts from around the world, and that's what we have today. We have Dr. Jun Gong from Cedar Mount Sinai, correct? Is Cedar associated with UCLA or no? I'm sorry, I should know that.
No, it's Cedars Sinai Medical Center, and we are in Beverly Hills here in California. We are associated with UCLA. We are a collaborating institution with them.
Lovely. Thanks. I'm glad you clarified that for me. So it's good to know. Hey, Jun, thanks so much for joining me here. So I saw our friend and colleague, Steve Freeland, at the American Urological Association meeting. And I was like, well, great. I can kind of corner him to be on my podcast because he's written a lot around diet and prostate cancer, which is one of the pillars in my approaches with prostate cancer. And so I said, and do you know anyone that the hot topic is glutamine as it relates to prostate cancer? And I don't know anyone. He says, oh, I know someone. He mentions your name and he introduces us. So I'm so grateful for you to be on and share your expertise around this very important topic. As you know, I had Dr. Thomas Seyfried on the podcast that talks a lot about the metabolism of cancer and prostate cancer. And he mentions glutamine and so forth. And we will expand on that. That's episode 100. I know that because it's, a milestone episode with Thomas Seyfried for those that want to listen. And so we're going to be able to, I think, share some light to our audience here. So let's start with this. It's been a while since I've taken a biochemistry course, but to the best of my memory, there's about 9 essential amino acids in the body and about 11 that are non-essential. And for the audience, that means that the essential ones your body cannot make. You need to consume it through food or supplementation. And the non-essential are your body can produce from other amino acids and other pathways and metabolic pathways. If that's the case, then and then glutamine is a non-essential amino acid, meaning that it's made from other amino acids. So A, correct me if I got 1 or 2 digits off there, and 2, and B, give us an overview of what glutamine does to the body.
Sure. You are right, Dr. Geo. Firstly, let me thank you for inviting me onto this platform here, and congratulations on your success and having 100 plus episodes. It's a milestone, and thank you to my mentor, Dr. Stephen Friedland, a colleague of mine here at Cedars Sinai, who's mentored me on numerous grants already and exciting research, for introducing us together on this collaboration. But you're absolutely right, Dr. Geo. The glutamine is considered a non-essential amino acid. It's actually the most abundant amino acid in plasma, in our blood, in humans. And it's considered non-essential because our body can get it and synthesize it from the food that we eat. Mm-hmm. And however, it becomes conditionally essential, especially for cancer cells like prostate cancer cells to grow and survive when there is increased demand during these periods of rapid growth and proliferation. And what we've learned through extensive research in this arena is that, firstly, prostate cancer, although other tumors may be very glucose dependent, if we were to say what's one of the most important nutrients for cancer growth, glucose could be 1A. Glutamine could be a close 1B here. What we do know is prostate cancer tends to be less glucose dependent or less glycolytic. And we've kind of known that in the clinic as well, because we generally don't use FDG, avidity PET scans for prostate cancers, because we've known of this knowledge. They tend to be more highly lipogenic. And of course, they're dependent on androgen signaling as well. But what we've shown with prostate cancers, what we've learned from prostate cancer cells, is that through glutamine, it's actually, firstly, it enters through the cell through a special family of transporters called the solute carrier, or SLC family of transporters. And once they enter the cell, or the prostate cancer cell in this regard, they undergo several fates. And this is where glutamine and a little bit of biochem comes back into play. Mm-hmm. Glutamine can serve as really 2 important sources. Its nitrogen can serve as an amide. Its amide nitrogen can serve to synthesize nucleic acids, both purine and pyrimidine nucleotides. And it can also be involved with another pathway called hexosamine biosynthesis pathway, which is important for protein glycosylation. The rest of the glutamine, its carbon skeleton and its other alpha nitrogen, gets converted to glutamate by special enzymes in the cell. And this is where it supports the energy demands of the prostate cancer cell. This is where the glutamate then fuels and funnels into the TCA cycle, which we all may know is very important for mitochondrial oxidative phosphorylation and production of ATP and energy to sustain the cell. So there is a lot of different pathways by which glutamine feeds into prostate cancer cell growth. And we like to collectively call that intermediary metabolism, because glutamine kind of funnels into a lot of different pathways to support prostate cancer growth.
Okay. So then so you mentioned, you said a lot there, and our members, our subscribers, they're self-health advocates. A few practitioners that can hang with you here with the medical jargon, scientific jargon that I can appreciate. many of the pathways that you mentioned actually are for cellular health. It's not to promote disease or carcinogenic cells or of any kind. The last few that you mentioned do promote potentially prostate cancer, or not potentially, they do seem to promote prostate cancer. Development and progression, actually, that's a question. So there's a difference when I talk to patients about, or when I talk about prostate cancer, it's not just prostate cancer, right? I'm looking at, well, how is prostate cancer different than any other cancer, A? And is the approach that reduces the risk of getting prostate cancer and developing prostate cancer different than the approach, once you have it, to reduce the risk of progression of prostate cancer? So in your research, based on the pathways that you've studied, is it more related to the development of prostate cancer or the progression of prostate cancer, or both?
That is a very fundamental question, Dr. Geo. And I would like to reemphasize your points. You're right. A lot of these cellular processes are normal processes that our bodies and our cells go through all the time. It's just, for some reason, cancer cells have learned to hijack these pathways and kind of use it up in a ramped up kind of pathway to sustain their growth. And to answer your question, it's very controversial. I think there is a robust body of evidence that glutamine is a dependency on glutamine metabolism. This does promote progression and evolution of prostate cancer. And there's been a lot of studies beyond our group too, where even castration sensitive prostate cancers, if you look at their metabolism of glutamine, it just gets ramped up and very turned into a higher level of pathways metabolizing glutamine when they transition to castration resistance. And they've done nice experiments where they've used castration sensitive mouse models. They've measured the enzymes, the glutamine pathway enzymes, the levels, and then they looked at it in the castration resistant models, and they're definitely much more higher. And if you block that pathway, it actually has anti-tumor effects. Now, with the development, when we did research in the early stages of prostate cancer, now moving from the metastatic setting to more localized setting, it actually didn't have a strong signal of, we were looking at it, does this predict for biochemical recurrence, for example, if you have higher levels of glutamine, for example, or metabolism? We actually didn't see that signal. There was no significant association with glutamine levels in the localized prostate cancer setting. So that's where I kind of pause. And when I say with confidence, does it contribute to development of prostate cancer? I don't think so. I can't say for sure. I think the research still needs to be looked at for that.
All right, let's break that down a little bit. We know that once you're diagnosed with prostate cancer, or if I have 10 people in my office with prostate cancer, those are 10 different types of prostate cancer, right? Low risk. One would say that if we look at the histopathology and as a Gleason 6, some would say, well, let's not even call that cancer because it's so indolent. We have low intermediate risk. We have high intermediate risk. We have high risk that is non-metastatic and closed in the prostate based on, again, histopathological results, the Gleason score. We have high risk that outside of the prostate, high risk in the bone, high risk, neuroendocrine cells that are more aggressive and metastasize to soft tissue, lungs, brain. Where would you think glutamine applies here? For example, if I have a Gleason 6 patient on active surveillance and they're doing my dietary protocols and my lifestyle protocols, is that someone that I should say, listen, limit your glutamine or no? And we can go one stage at a time if you'd like.
Right. This is a great segue. I like the way you're thinking and the way you're going. I would firstly say that the nutritional deprivation of glutamine in our diet is very controversial.
Right.
The evidence that we've been doing is more medicinal, therapeutic blockade of, for example, glutaminase is one of the key enzymes that converts glutamine to glutamate. You may be aware that there was an agent out there called CB8139. It's from Calithera. That was one of the first glutaminase inhibitors to hit the market. And it was in phase 1 trials in prostate and other tumor types. Unfortunately, that didn't pan out. There was no real therapeutic benefit, and so that drug has been out of development now. And so I just wanted to emphasize that point, that we really are still in the stages of looking at therapeutic blocking. So to jump to a diet standpoint, we actually don't have good evidence of in regards of glutamine deprivation in the diet. So I think this is where we
Right.
rely on experts like you with the more broadly speaking nutritional diet approaches, whether what's the research leading into for that. And so back to your questions about the different stages of where I think glutamine is most active in research and where we have the most robust evidence. This is again keying in on our knowledge of therapeutically, pharmacologically blocking this pathway. I would have to say I don't. It hasn't really, I think, been established in the localized setting. So your Gleason 6, even your 7 and 8s, your intermediate risks, or your 7s, where we looked at in our localized cohort, it was intermediate risk. There wasn't a clear signal. High risk, I don't think it's been specifically looked at. But once you jump into the advanced prostate cancer setting where they're metastatic disease, MCSPC, MCRPC, neuroendocrine, we definitely showed neuroendocrine is one of the highest glutamine addicted subsets of prostate cancer. So it's almost like you see this transition from MCSPC to MCRPC and NEPC, where the glutamine dependency, or they've termed it glutamine addiction of the prostate cancer, is really amped up.
Fascinating. Even in very aggressive and neuroendocrines, I think that a PDG PET scan actually would show, it would light up, which means, and for the audience, PDG scans, PET scans are when they use glucose molecule as a tracer. And so then the cancer cells sort of gobble up this tracer, and then you can see it on an imaging. So if the prostate cancer is encapsulated, many would say, well, glucose is not sensitive to this prostate cancer because you don't see it lighting up in the prostate. Once it's out of the prostate and the cancer is more aggressive, you do see, not PDG, FDG, right? FDG PET scans are more sensitive, and the glucose is more sensitive as a tracer in that circumstance. So maybe there's kind of the both things. There is a glycolytic element to it, and there's a glutamine element to it at that point. Fascinating. So back to the original question, right? Because I think that I'm glad you said about, look, there's no research on the dietary component, because then it's like, look, diets are very difficult. They're confusing. It's like, religious also. So you're part of this tribe, that tribe. You're the ketogenic person. Oh, no, I'm the paleo. No, I'm the plant-based. And there's always like these arguments that you see in Twitter or X or whatever and online. And I think, I'm like in politics, Kai, can we get along? It's like, can we all get together and get along as opposed to so much separation, right? I think that's my overall philosophy in life. And that's certainly my philosophy as it relates to diet work. And so I'm glad that you mentioned, look, we don't know if it's, if does it increase the risk of prostate cancer? We don't know. Dietarily, does it increase the risk of progression once is still in the prostate? Well, we don't know. Once it's out of the prostate and more aggressive, that's when you see there's more signaling occurring. Am I correct on that?
That is absolutely correct. And even if, and here's the point where this is where patients I'm sure they've asked you too. They say, well, if this nutrient is so important, why can't I just go on a nutrient free of that nutrient and starve the cancer that way? And there's various forms of that.
It's everywhere almost. You can't.
It's everywhere. And we've shown, other groups have shown too, that the cancer cells, well, even if you deprive them of that, they have some kind of compensatory a way to overcome and still get the nutrients from other sources, other pathways. And we've shown in other tumor types that actually, if you actually deprive the glutamine pathway for too long, they actually become even more aggressive and they can grow in that way. So that's where I tell patients, it's a little bit controversial. We've been trying to block this pathway, but in other tumor types, it doesn't work, and it even makes it more resistant in a way. So we really need to, I think, study it in a safer fashion than to have patients really engage in these diets without research and experts like you counseling them on the ways to approach it.
And not to mention the benefits of glutamine, which we're overlooking. So it's almost like cholesterol. Let's just drop cholesterol. No, we need cholesterol. It's an important molecule in every cell of our bodies. Is important for the production of sex hormones, and it's very important. So it is not as simple as just low everything or high everything. It's more nuanced than that. Glutamine benefits, integral part of your immune system, right? Important for lymphocytes and macrophages and production and health of those immune cells. The integrity of the intestines, right? Is crucial. It's like food for your intestines. In the naturopathic medicine world, glutamine is a key component for gut health in terms of even supplementation, brain function, wound healing. So one needs to be very careful, and I think the audience, because what tends to happen here, Jun, and I think you've seen that, people will hear, they hear what they want to hear, first of all. So those people that are listening to this and already think that glutamine is bad, they're going to go further away, despite of what we're saying, that, look, we don't know the dietary influences on prostate cancer as it relates to, the disease. So it's a very important nutritive amino acid. I think it should be carefully, in terms of supplementation, in my opinion. I provide glutamine as a supplement, Jun, and for those that are undergoing, that's part of the nutritional prostatectomy protocol for wound healing, right? But after they're done with that, then we get them off. People with digestive issues, get it as well. And so in the naturopathic world, they're supplied with supplements and things like that. Other than that, in the more aggressive approach, I definitely get them off of glutamine. And there again, I don't know what's dietary. Why does it go this pathway and not the other? Why is it feeding the cancer cells? Thomas Seyfried, and I want to hear more from you. I know I'm kind of jumping around a little bit. Welcome to the Dr. Geo Prostate Podcast. I want to hear from you. But Thomas said, Dr. Seyfried said, and I looked it up, and he's right. One of the best ways to reduce glutamine production or deviating the pathway into other pathways that doesn't stimulate cancer cells is exercise. Exercise, which is number one in my protocols, is like you have, very prescriptive. So all that said, so let's focus then on those with more aggressive prostate cancer. What do we do? And is there anything out there? I mean, exercise, even men with aggressive prostate cancer tend to do very well with that approach and other lifestyle approaches. Is there anything else that we know that can reduce the metabolism of glutamine in the cancer cell itself?
Dr. Geo Prostate Podcast likes to bring you a fast fact about AG1 by Athletic Greens. AG1 is formulated with bioavailable ingredients that actually work with your body. Its powder form makes it easy to digest, so your body can access the nutrient-dense ingredients it needs. Try AG1 today and get a free 1-year supply of vitamin D3 plus K2 and 5 free travel packs with your first purchase. Click on the link and enjoy AG1.
So glutamine is essentially in all the foods we eat. You can list from protein to dairy products. It's wheat. It's all there. So it's really hard in that regard. I completely agree. Exercise, that's something that we support as well. It really does the body wonders. But I think that magic bullet still does not exist as to how to restrict glutamine. And I'm not sure if it's just restricting glutamine or one of its downstream intermediary pathways is the key here, or whether glutamine is just a good biomarker. because I actually completely agree with you, Dr. Geo, that glutamine supplementation is kind of it's like a 180. But believe it or not, I am leading a clinical trial right now of high dose glutamine in pancreatic cancer.
Oh,
Believe it or not, which is a complete 180 from
what's the hypothesis there, that it helps or is more or it makes things worse?
So this is where when I stepped into the prostate cancer research arena, the field was block glutamine metabolism, not just block glutamine in the diet. It's whatever the cancer cells take in, the pathways there. And when we apply this to other tumor types, pancreas cancer, for example, we saw that when you deprive them of glutamine, they eventually grew, they overcame, and it was almost like they were getting angry and pissed off. And we looked at the literature, and there's high profile papers in Nature that show if you block glutamine metabolism in pancreas cancer, it fails. They have metabolic pathways, compensatory pathways of resistance. So I don't think this is the way science is supposed to work. We were stumped, or we were sitting around the table and we said, well, what happened if we flood it with glutamine?
And so are you looking at animal studies?
Yes, yes. And so, like I said, I think this is very serendipitous, but it's not the way science is supposed to happen. We found this body of evidence that you cited, Dr. Geo. Glutamine supplementation has been around for decades, supporting gut health, immunity, you name it. And there's actually an FDA-approved glutamine powder for sickle cell anemia. It's called Indari. It's FDA approved, and they used it to reduce sickle cell crises. And so when we tested it in our animal models, we actually show that with high levels of glutamine, and this is shown by other groups too, you actually cause cancer regression in the animal models. So it was then me connecting with the only FDA-approved glutamine product at that time. And we developed this IIT, which is available on clinicaltrials.gov. It's a phase 1 trial of glutamine supplementation in combination with standard of care chemotherapy in pancreas cancer. And so that is ongoing right now. So that I think this just adds to the both sides of the picture of we're not. I think the evidence is evolving. There's two sides to this picture, and it may be tumor dependent. It may be something biologically different with the tumors too. We know that pancreatic cancers are KRAS driven, and KRAS does manipulate or regulate the glutamine pathway a little bit differently. But this is a very exciting time for this area.
Fascinating. Many of the patients I see, they see natural oncology doctors, integrative oncology doctors. And what are these are doctors that are looking at out of the box type of approaches. Some of them actually they're not too way out there, I would say. They're utilizing science as best as they can to help patients with stage 4, and there's really nothing else they can do. So some of them are a little bit way off, I think, right? There's these cancer clinics all over the world, Mexico, some of them in the US. Again, some of them are legit, in my opinion. And Dr. Seyfried once again mentioned a drug that it's used as an antiparasitic drug and used off-label to reduce or inhibit the production of glutamine, and that's fenbendazole. Your thoughts on the utilization? And I know that you're ultra science based, and if the science doesn't show it, we don't say it, and I'm okay with that. But also, is there any remote possibility, if there's no science to support that in humans, that it may work?
I think so. If they're preclinically, I think there may be data to support that. I will always tell my patients the right setting then is probably to investigate that in a clinical trial. And we have clinical trials of believe it or not, one of my
For this
colleagues,
particular purpose of
I think one of my colleagues has a clinical trial of ivermectin, for example, plus standard of care therapy. And
for what type of cancer, Jun?
This is breast cancer.
Okay.
And Dr. Yuan, someone you may want to connect with, is doing that trial here at Cedars Sinai and other, I think.
Please connect me. This is how I get the best of the best. So I appreciate that. Yeah.
Yeah. And so I think that I use that as an example of just what I tell my patients is the right way. I obviously don't have knowledge of the definitive evidence and it should be put through trials. And I think that's the right way to answer it in the safe kind of setting. Other than that, I don't routinely recommend febendazole either off-label for this purpose, especially in the treatment of prostate cancer patients. But I would not opposed to learning more about it, and I would not be opposed to pushing it and seeing it push through the scientific kind of method and into trials, for example.
So based on what you know on fenbendazole and its potential anti-glutamate activity effects, there have been some studies to suggest that, preclinical studies, but it's never been studied in humans. Is that the deal?
I'm not aware of any clinical trials in humans of febendazole, for that matter.
But in preclinical, as best as you know, and I won't hold you to it if you don't, but it does seem to have anti-glutamine effects in preclinical trials, as best as you know.
I have to be honest. I'm not too familiar with the preclinical data. I have heard it mentioned along with some other class of drugs that can, because when these drugs have anti-metabolite properties, they broadly can affect multiple metabolic pathways.
Sure.
So I would not be surprised.
Not in a positive way, by the way. They affect many metabolic pathways, not all in a positive way, because you do need glutamate for all the things that we mentioned before.
That is true.
Right.
That is true.
Right. So animal studies, which you're working on now, one of the concerns is, it doesn't always translate to human studies or human effects. So if there's this positive studies from animal studies, it doesn't always translate, like the glutamase inhibitor that you studied that seemed really good in animals, but then it didn't seem to be as good in humans. What's what's in the pipeline? What's being studied that you think will have legs eventually, particularly in men with advanced prostate cancer? Is there anything out there that it's being studied that you say, I think hopefully, again, I won't hold you to anything. I know how strict you are to the actual science, and I appreciate that. But what's out there right now? What's being studied?
I think the exciting areas in prostate cancer, specifically, I think neuroendocrine prostate cancer has really shown to be among the most glutamine addicted types of cancers here. So, and that's a high unmet need population there. So I think there is a lot of exploration into glutamine. Can we use that as a signal, as a biomarker that, hey, these patients are at risk for transforming into these aggressive subtypes, and then ways to treat them. In the other topic that has been really exciting to us, at least, Drs. Bolmick and Dr. Posadas, who are all my colleagues here at Cedars, they published a paper a couple of years ago that showed that the potential source of glutamine that is increasingly being used by the prostate cancer cells is actually maybe coming from the tumor microenvironment. These are called stromal fibroblasts. These are the support structure cells around that support the prostate cancer cells. And this paper, which was published in JCI, it's very fascinating. They showed that it wasn't until you were exposed to androgen therapy, androgen deprivation therapy, that you then upregulated the pathways in the fibroblasts. And they took proteins from the environment, albumin, you name it, through a process called macropinocytosis. And they took that in and they released glutamine that was then used by the adjacent prostate cancer epithelial cells.
Beautiful.
And so,
Beautiful description, beautiful study. I'm going to gobble that up right after we're done here. Sorry to
our
interrupt.
next
I'm
step,
so excited from hearing
yeah.
you.
So that I think that was that opens a whole new avenue of, I think, maybe leading to your original question of how do we block this pathway in a safe way, because there is nutritional benefits of glutamine as well. I think our group is saying you got to look at the stroma too. What's feeding the prostate cancer cells. It may not just be them sucking it up from your diet. It's something happening from another player. That's and then our treatment may be triggering it as well. But that's a very complex question. I'm not going to say androgen deprivation therapy is bad for us. It's just
no. But here's where I'm going with this. With my patients on ADT, okay, so understand, my patients see me for two reasons. Number one, I'm sort of their prostate cancer navigator. Hey, I have this, that. What do you think I should do? Even from a medical standpoint. And then, what are the natural and lifestyle approaches? With my ADT patients, I have two goals. Number one, reduce the side effects of the ADT as it relates to metabolic syndrome, cognitive decline, pretty much everything except sexual function, because I think is very difficult and I don't have an answer for that. Number two, prevent castrate-resistant disease at all costs if I can. So the conversation that we talk about is, okay, so I went to Dr. G, I went to my oncologist, they put me on Lupron, whatever. And I'm saying, all right, good. Now, when are they going to put you off Lupron? What's their cutoff point where it's, okay, a year with an undetectable PSA, okay, let's get you off and let's give you a break. Let's do it intermittently, because we want to avoid, by all means, castrate-resistant prostate cancer. And you're mentioning one of the pathways related to glutamine. And this is why I kind of cut you off. And I was like, look, as a scientist, I'm not a scientist. I'm a practitioner. I'm a clinician. I get excited. You're not supposed to be excited, right? You're supposed to kind of even keel. Don't get too excited over conclusions or results. But, I'm a human and I want to see patients do very well. So to give me some guidance, wow, there's a glutamine pathway when the cancer becomes resistant that may promote, the aggressiveness of prostate cancer. This is, for me, is beautiful, because this is what I'm trying to do here. I don't want them to get resistant to the disease. So, wow, that is amazing. For the audience, we spoke a lot, and I don't think many of them know what neuroendocrine is. Neuroendocrine, and Jun, I'll let you chime in as well, because I'm going to summarize. Neuroendocrine is a more advanced disease that typically, in my experience, is found when the PSA is actually low, not high. There's a low PSA. Sometimes I've seen patients with a PSA less than 1 with very aggressive disease. Now, that's probably, if I remember correctly, no more than 2% of the population with prostate cancer who have a low PSA and aggressive cancer, or they had prostate cancer, was treated, and now it became a neuroendocrine disease with time, where that means is very aggressive, and it typically spreads beyond the bone quickly to soft tissue like lung tissue and brain. Is that pretty much right, Jun?
That is absolutely correct, and it behaves differently from what we've known of classical prostate cancer. Like you said, it's not PSA secreting. It's learned its way to not be androgen dependent, and I think that's where the unusual metabolic dependencies you've hinted at, it becomes more glucose dependent and more glutamine dependent, hence where FDG PETs can pick up neuroendocrine prostate cancer. It's like a different entity that's very aggressive, and you're right, it is often therapy induced eventually through resistance pathways.
I've had Alicia Morgan on, medical oncologist from initially Northwestern, now she's at Harvard. And our conversation was around intermittent ADT. And I raised a provocative question. I wonder what your vision is, or what your what you think of this. When there's a recurrence of prostate cancer after treatment, we don't know exactly when to pull the trigger and get them on ADT, right? We're just PSA dependent. And if it starts inching up, it's like, oh, right away, let's get them back on ADT. I don't know about that. But I also don't know when you do pull the trigger. I always say to patients, I don't know, but it's not 0.2. I don't know, 0.5. I mean, there's some ambiguity here, and you have to, depends on your risk tolerance and your conversations with your oncologist. What are your thoughts on so there's a recurrence, they had a prostatectomy, radiation, whatever. It's a recurrence. Well, the PSA situation is a little bit different. So let's just stick with, they had their prostate removed and now their PSA is rising and they had radiation and then it's still rising. So there's a recurrence. When would you say, all right, now you need to be back on ADT, including patients that I have on ADT who they get off of it 6 months later, starts inching up, whatever the number is, 0.2, then it goes 0.3, 0.5. And I'm like, okay, maybe we can wait till it's 1.0, or wait until something comes up on a scan. So what are your thoughts? What would you, and if there's any research, please let me know. I don't know of it. And what would you do in that scenario as a clinician? What would you advise?
Well, I think this is where Dr. Friedland would be a nice conversation piece here because of his recent positive trial on the EMBARK study.
That's right.
I think they provided a little bit more, they shed some insight into the patient populations where these are high risk for recurrence now after definitive therapies. And they, the Gleason scores, the tumor histology from surgery, these are features that can help predict which patients you get on. But to kind of piggyback on your question, Dr. Geo, I think they've most importantly given us insight on possibilities of when to stop too. So on the EMBARK study, if you reach the PSA threshold by, don't quote me exactly, about 30 months or so, then you can stop. And I think that was wonderful for them to answer when to start, not the populations to start, but also when to stop in the high risk setting. In the metastatic setting, you're right. We don't have really clear evidence. The convention has been you put patients on indefinitely on ADT. And patients, it's a big quality of life impact. But I think we are recognizing that as a field and we're trying to answer these questions now. So I'm aware at least of one study. It's an ongoing study. It's a phase 3 Libertas study.
Phase 3 what?
Libertas, Libertas.
Okay.
It's ongoing. It's metastatic prostate cancer patients. They're randomized to, I think, what happens is they get Erleada, which is one of the ARSIs, plus Lupron. Mm-hmm. And if they, after 6 months of therapy, if they reach a nice PSA response, this is where the study seeks to answer that question. They randomize them into intermittent ADT at that point, or the standard continuous ADT. So I think the field is responding and they're listening and they feel like we need evidence to guide our providers of when to stop Lupron or ADT in general.
Beautiful. I want to be respectful of your time. It's probably working hours for you out west, and I would love for you to get back to work. I have, I could probably be on here with you for another hour, but again, I'll be respectful of your time. Maybe we'll invite you again. Dr. Jun Gong from Cedars Sinai out in California, LA. Thanks for being on, and maybe just final words and how can people learn more about your work?
Thank you, firstly, Dr. Geo, for inviting me. It's my pleasure to be on this exciting platform. I think if there's any takeaway points, it's that we don't have a clear answer whether starving your diet or supplementing your diet with glutamine is the right answer. I think here we leave it to experts and your professional colleagues about how to guide the best kind of balanced approach with your dietary approach, but that keep an eye out in the future. There is a lot of exciting research in targeting glutamine metabolism. And I think there is a pathway forward in learning how to overcome therapeutic resistance, evolution to more aggressive states, and ultimately improving patient lives with prostate cancers with this pathway.
Great. Is there Thank you so much for sharing that. How can people learn more about your work, Jun?
Well, I think they can. We have public channels. My name is searchable on our Cedars Sinai profile. Obviously, patients in need have my direct patient servicing line, and my email is also available to the public as well for personal communication.
Beautiful. Thanks so much once again, Jun. I really appreciate this conversation.
My pleasure.
Thanks everyone for watching this other amazing episode here with leading expert in glutamine and prostate cancer. So I'm super stoked. And again, I'm Cuban American, so I cannot hide my emotions when I'm excited about things. But I do moderate it. At the end of the day, I just want to make sure that the listener, my patients, not only survive after prostate cancer, but thrive. How can I even do better after this diagnosis? That's the goal here. So thanks so much for tuning in. I'm sure this was valuable to you, actionable insights, and I'll see you at the next episode. So long, and I'm signing off. Dr. Geo signing off. Much love. Talk to you next time. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.